Hi everyone. Welcome to UCL. Hi, I'm Sonia Johnson. I'm from the Mental Health Question Time organising team, and I'm a professor in the Division of Psychiatry at UCL. Thank you very much for all making it in person to come to this discussion this evening. It's become probably harder to fill a room in recent times than it used to be, so it's fabulous to see you all here, and also thank you very much for joining us. To those who couldn't make it but are here online, we'll make sure we pick up your questions too. So it's fantastic to be hosting this evening's event. It's the restart, the relaunch after several years of what was a lively event before the pandemic. We had a series of mental health question times here at UCL, hosted jointly by Lancet Psychiatry, the Mental Health, and the UCL Division of Psychiatry. It's brilliant to have the chief and founding ELF with us here this evening in the front row, Andre, sorting out all the technical and outward-facing stuff for us. It's also great to be still in partnership with Lancet Psychiatry and to have Sophia Davis here somewhere. There she is at the back. Thank you very much for being part of our partnership as well. We're also really grateful to the UCL Grand Challenge in Mental Health and Wellbeing for financial support for this evening and support in organising this event. That's a cross-disciplinary partnership led by Argyris Stringaris and Essie Vidding, which is trying to form collaborations across the institution and beyond to address the major societal challenges that are associated with mental health. I'd like finally to draw your attention to a programme of research that quite a few of the panellists have had involvement with, and that is one of the sort of starting points for this evening. I'm director of the NIHR Policy Research Unit in Mental Health. We had suggested by our lived experience working group that mental health care for autistic people should be a very high priority for research to inform policy, which is what we do. And so we've published a couple of major systematic reviews. Well, one of them is already published, and you can get it on the QR code in the corner, and the other will be out in the next few days. We've reviewed all the literature we could find on mental health care for autistic people. For one review is on children and young people, and the other on adults. And we've looked for all the evidence we could find on adaptations of standard interventions and on innovative interventions for mental health support for those groups of people. So please do take a look at those reviews. There's less evidence than you might hope, given the importance of this, but we still feel it's an important starting point. I finally just wanted to say, please come for a drink afterwards downstairs in the foyer. The networking afterwards has always been a crucial part of these MHQT events. So finally, I'm very happy to hand over to a colleague from Psychology and Language Sciences, Professor Will Mandy, who's this evening's chair and a leading expert in this field of mental health care for autistic people. Thank you, Will.
Brilliant. Thanks so much, Sonia, for that introduction and for doing so much to make this whole occasion happen tonight. So I'll just start off with a few bits of housekeeping and things on timings. So we've got till 6:45 for, you see, we have a wonderful panel assembled here who I'll be introducing in due course. For initially, I'm going to ask each of them a question whilst and sort of through that introduce them to you. And then we'll hand over and see what happens. And we'll have hopefully a really interesting discussion between you, the audience, and our panel of experts. Now, there are no fewer than 4 ways you can ask a question. So you can do the old-fashioned way, put your hand up, and someone will come and bring a mic over to you. There's Mentimeter, which I believe there's a QR code, brilliant, that Ruby's going to show, so that you can, you can scan that and it will take you somewhere on your phone where you can write your question in. There's Twitter, and I believe also, for those of you who are watching out there on YouTube, you could also type your questions into the YouTube comments, and Andre will pick them up and ask them for us. One other bit of housekeeping. We have a quiet room in case anybody would like to make use of that. What you should do is just head out at the back of the lecture theatre, and then Sophia and Ilaria are there. Can you see them just waving there? And they can help you, direct you to it. It's not far away, but it's a little bit of, there's a couple of minutes, I believe, so they can help with that. Okay, so just to give a little bit of background before we get going, autism, of course, is not a mental health problem, but autistic people are at very high risk of developing mental health problems. So, for example, we know that around 7 in 10 autistic children meet criteria for a mental health diagnosis. And similarly, of course, amongst adults, we also find really high rates of mental health difficulties. Despite this, despite the fact that autistic people have a high chance of developing mental health difficulties, unfortunately, they currently have a low chance of receiving effective help for those problems. And this is because things like the mental health challenges of autistic people all too often go unrecognized. And of course, autistic people very often struggle to access services that are effective and inclusive for them. And this is really the context for our discussion tonight. A recognition of the urgent need to find better ways of preventing mental health difficulties of autistic people, and also the need to develop better services so we can get better at recognizing and helping with the mental health problems of autistic people. So to engage with these matters, we have our wonderful panel here. So as a panel, I'll be introducing them one by one as I ask them their questions, but I'd just like to point out they combine really diverse experience, including lived experience, research, clinical practice, policy work. So I'm very much looking forward to what's going to unfold here in the next hour or so as we discuss this really important topic. So we'll start with Dr. Eloise Stark. So Eloise is a few months from qualifying as a clinical psychologist in the NHS, and is also holds a PhD and is a research fellow in the Centre for Eudaimonia. Did I get that right? Excellent. And human flourishing at the University of Oxford. And my question for you, Eloise, is, in your view, why are autistic people at such high risk of experiencing mental health problems?
So, thank you for having me here. And a little bit closer. Is that better? Yeah, thank you. We've got this mega mic here, so we've got 2 in 1. If I drop it, I apologise in advance. So yeah, my name's Eloise. I'm an autistic woman, and I would like to name that my neurodivergent identity is really central to my experience here, but only one of the experiential positions that I can speak from and navigate within. And the other 2 that are kind of, I guess, more important today are being a clinician, going into the NHS, qualified very soon, but also being a researcher. And navigating those 3 is really tricky, but brings a lot of joy. And alongside reflecting on my own experience, I think it's really important to name the wonderful people I've been lucky to work with clinically who are autistic or neurodivergent. And yeah, I've learned a lot from them and continue to do so and hope to keep doing that. So yeah, I think my first research was in the cognitive neuroscience of parent-infant interaction and attachment. And I think that's really important because it's about feeling connected, loved, supported, understood, and safe. And those are things I think are really important to build into mental health care. And yeah, I think my question was slightly different to the one you said. So I think it was about what do we need to do to build better healthcare was the one
Okay.
I've got.
Yeah. Well,
So-
thank you. It would be brilliant to hear from that.
Yeah.
Thank you.
So I've got kind of 3 points, and I think there's about a million more, but I'm going to talk to these 3. So I think assumptions are a really key point, and assumptions of autistic people and their mental health can lead to misunderstanding at best, but harm at worst. And I think as a profession, we've done a lot of harm. We still do a lot of harm, and we always will do, because we're human, we make mistakes. And I think having professional humility to understand that we need to always know that we can do harm, that we can do good, but that we need to be thinking, what am I doing right? What am I not getting quite right? How do I improve? How do I change? And having that humility as our central kind of value is going to be really important in addressing some of these changes. And Will and I were talking earlier about how mental health and autism has changed dramatically in the last few years, let alone the last 10. You know, we talk about it differently, we think about it differently, we diagnose vastly more people. So we've got to change. I also, second point, I don't have answers, but I have curiosity, and I have privilege and power, and I have privilege and power in sitting here right now, and I can speak and be listened to, and not everyone who's autistic or neurodivergent has that power, and I want to speak to that and say, I will do my best to be curious, but I want to acknowledge that I don't have the answers, and I couldn't have the answers as one individual. And that's why we need community, we need people thinking, we need people challenging, we need people saying, I don't agree, and people open to going, okay, what do you think? And I also think it's really important to provide epistemic justice to people who maybe aren't typically listened to. So people with learning disabilities, autistic people with learning disabilities, people from the global majority, people who are non-verbal, and all of these intersections, because we aren't in a vacuum, we aren't in silos. And the last thing, I think, is that we've often been criticised as a profession, as clinicians, for pathologising the individual rather than thinking about the disadvantage related to systems and the environment around someone that oppresses them. And I think there's a clear approach needed individually, and we need better treatments, we need more adaptations for autistic distress, but we also need to have a look upstream and go, what as a profession do we need to do? What can we see on the ground that shows us what we need to do upstream to prevent these people getting further downriver? And I think that systemic approach alongside refining our individual approaches in mental health care is really important. So yeah, I'll stop there, but
thank you very much,
to
Eloise.
say.
Yeah, that was excellent, thank you, and I'm sure to be continued on many of those themes. So next I'd like to introduce Amanda Timmerman. So Amanda is an autistic PhD student at UCL in the Department of Clinical, Educational and Health Psychology with lived experience of using mental health services. And Amanda, the question for you is, what barriers, in your view, do autistic people face in getting help for their mental health problems?
Hi, everyone. So I'll be primarily speaking from my own lived experience, also as an autistic person who has co-occurring physical health conditions as well. I've got kind of 3 key points.
Ooh, could you put the mic a bit closer to your mouth?
I think it's confusing because the best one to speak on is this one this one. It looks like the one you shouldn't be on, but the smaller one, yeah, sorry.
I'll
Yeah,
do
brilliant.
3
Sorry, yes.
Thank you, Lo. The first point is there are kind of limited contact methods when seeking support. So current systems for accessing support seem to rely heavily on phone calls. There's limited signposting or flexibility regarding alternative contact methods, particularly when self-referring. Provisions such as text relay do exist, but they aren't understood to be for those with social communication differences. So if not kind of directed to use those alternatives, as an autistic person, I then feel pressure to use like the typical methods to try and access support. Where phones are involved, I'm also more likely to feel uncomfortable and anxious. So I'm highly likely to be masking, which I'll kind of detail a bit more in a bit. And this results in me and other autistic people I've talked to typically failing to communicate important information for the support that they need. Then my second point, there needs to be more awareness and understanding of masking, that it can be both conscious and unconscious behaviour. that it's not something that can be simply just switched off, that it can change depending on the context and people present. Also, how well someone is masking can vary for multiple reasons. It can also overshadow both physical and mental health symptoms. And ultimately, masking can disrupt the therapeutic process. So there's a need to help an autistic person to kind of unmask or mask less when they're, during the course of receiving that support. And then my third point, if I can, one-handed. I'll do it in stages. Aha, there we go. So my third point is the kind of structured treatments that are usually recommended in the first instance. Oh, closer. I can't hear. Okay, I'll try and continue talking.
Yeah,
okay.
you're doing great.
So yeah, structured treatments seem to have little room for investigating autistic differences and their impact on health. So for example, if an autistic person goes and they're recommended or prescribed a low-intensity course of CBT, it might just be 6 sessions. This also extends to other factors that can be impacting on the mental well-being of the autistic person, such as other health conditions they may be managing and other aspects of their identity, which all come with their own social considerations, which would impact on why they're seeking support. Sometimes those differences feel like they're dismissed or trivialized or normalized in favor of sticking to the course of treatment and time constraints. It can feel to the autistic person that those elements are not needed to be focused on as part of the talking therapy they may be receiving, when they actually may be key elements underlying the difficulties that they're experiencing. And lastly, so potentially therapy may miss the target for the autistic person, and though they may be helped in some ways, other impactful areas can go unaddressed. Then the autistic person may still need support, but then they may feel discouraged to actually seek help again if they feel those areas would be disregarded. So kind of they might get helped halfway and then kind of get stuck somewhere. That's it.
Brilliant. Thanks so much for that. That's brilliant. Am I right that it's pretty hard to hear at the back? Yeah. Okay. So sorry to ask this to the panelists, but if you could sort of put the mic pretty close to your lips and kind of speak quite loudly. It sounds like that's probably our best wish, because I think we have got the volume already turned up to 11 sort of thing on the system. Okay, so next it's my pleasure to introduce Professor Dheeraj Rai. So Dheeraj is Professor of Neurodevelopmental Psychiatry at the University of Bristol, and he's also an honorary consultant psychiatrist at the Bristol Autism Services for adults. So my question for you, Dheeraj, is what does the evidence base tell us about which treatments work to help autistic people with their mental health?
Thank you. Well, can you hear me clearly? Okay. Please shout if you don't. So thanks for inviting me. And I'm going to stick to the evidence related to adults. But when we talk about which mental health interventions are effective or are helpful, the kinds of study we need for that kind of evidence is randomized controlled trials. And so the answer to your question is fairly easy, but a bit sad that there are very few randomized controlled trials for autistic adults in relation to mental health outcomes. And the evidence is relatively weak. It's also interesting to say that there have been trials which have actually been used where interventions for mental health problems were included as in one of the arms, such as psychotropic medications, antipsychotics or antidepressants, etc. Sadly, for those kind of trials, mental health outcomes were not even measured in such trials. And that was because until very recently, until about a decade ago, the focus of these kind of trials was looking at improving symptoms of autism rather than helping people with their mental health. Now, having said all of that, there is some weak evidence for cognitive behavior therapy, mindfulness, which comes from smaller scale pilot feasibility type studies. So not really strong. But recently, just a couple of months ago, there has been a new trial that was published, a Dutch trial looking at dialectical behavior therapy. It's quite a complex, very resource-intensive intervention. And after 6 months of DBT in that Dutch trial, they found that people who were on the DBT versus the treatment as usual arm improved in relation to their suicidal thoughts in terms of suicide attempts as well as depressive symptoms. We still have to figure out whether this kind of interventions are actually possible and it's applicable for the UK setting, for example, or other international settings. So the external validity of that kind of work is still in question. After being so pessimistic, I'm going to end with a note of optimism, because I think this has been no better time than this in relation to UK's randomized control trials landscape in relation to autism. And I know colleagues like James and Autistica have really worked hard to get that done. So we are, within the next 12 months, we should have 2 very large RCTs, the largest trials in the world on common interventions. One of them is a trial for sertraline versus placebo for anxiety in autistic adults. Very commonly used antidepressant. We don't know whether it works in that population. We don't know whether this medication has adverse effects which are unusual or different from the neurotypical population. So this trial, Strata, which I have the pleasure to lead from Bristol, is going to be reporting next year. And there's another trial called ADEPT-2, which is a trial of guided self-help for depression. This is an adapted version of behavioral activation, so based on CBT principles for depression. That too is led by Elsa Russell in Bath, and it's going to report next year. Apart from that, there are a few more feasibility studies underway, funded by the NIHR, supported by charities like Autistica, and I think in the next few years, we should have better evidence than we've had traditionally.
Great. Thank you, Dheeraj, and thanks for pulling it round to a more optimistic note at the end there. So next, I'd like to introduce Tamara Pemovska. So Tamara is a mixed methods public health researcher with experience in implementation science and mental health research. She currently works at the Centre for Evidence and Implementation, having previously led on an evidence synthesis project at the Mental Health Policy Research Unit, one of the projects that Sonia mentioned at the beginning, and that's focused on improving mental health care for autistic adults. So my question to you, Tamara, is what does research so far suggest is helpful in adapting treatments and services for autistic people?
Hi everyone. It's really good to be here, and thank you very much for the invitation. So I will answer that question from the lens of the findings from the 2 systematic reviews that Sonia introduced at the start. And so just as a reminder, our question was to identify and explore ways that have been used in mental health services to better meet the needs of autistic people and improve their mental health. So we were interested in strategies such as bespoke interventions specifically developed for autistic individuals, or adapted standard interventions, as well as service level adaptations and then strategies to improve identification of autism in mental health services. So basically, the evidence that we found pertained largely to the interventions as a whole, less so about the specific adaptations that were made. So we looked at basically children and autistic children and young people, and also autistic adults. And in both reviews, most of the evidence lies in testing CBT, or cognitive behavior therapy, for anxiety. Around 75% of the studies across both reviews were about this. A few studies tested some sort of service level interventions and even training for clinicians. And then there were a small number of studies looking at sort of bespoke interventions that specifically developed for autistic people, but even those were CBT based. So the evidence that exists at the moment, it surrounds largely CBT for anxiety. And but something important to say is sort of following from what has already been mentioned, is that the quality of the studies is not great. We are missing large-scale trials. There is more literature out there for autistic children and young people, but less so for autistic adults. And even though we included there were more eligible randomized controlled trials in the adult for children, in the review for children and young people, still these reviews had very small samples and definitely not conclusive. So what we found is that CBT for anxiety may improve anxiety in autistic individuals, but more evidence is needed. Importantly, coming back to the adaptations. So we basically took out from all the included studies all the individual adaptations that were reported in the studies, and then categorized them based on similarities to identify what kind of adaptations are made. We found that not all studies were reporting these adaptations systematically, which is an issue, because it's hard to reproduce this and then even implement adaptations in practice. And in terms of the evidence of what's helpful for these adaptations, we are largely here relying on qualitative accounts from clinicians and a few qualitative accounts as well from autistic individuals. But in terms of the where mostly what we found was that very few studies included environmental adjustments, which are often highlighted as a priority for autistic individuals. And most adaptations were around communication and intervention content. So, but because none of the trials, the randomized controlled trials, really investigated an adapted version of the intervention versus a non-adapted version of the intervention, we can't make any conclusions in terms of the effectiveness of the adaptations themselves, rather the effectiveness on the intervention.
And just,
yes.
yeah, just maybe one more point just to get through.
Yeah. So I think I actually will stop there with a summary that there is many gaps in evidence, and more high quality evidence is needed. And basically at the moment what we are finding is that principles of person-centered care are needed when it comes to treating mental health in autistic individuals. Thank you.
Brilliant. Thank you so much. And once again, just to remind our speakers, if you could sort of belt it out, if possible, speak quite loudly and put the mic close, because I've noticed occasionally a few looks of consternation at the back there when they can't always hear everything. So
I've been told I'm loud generally. No.
Good. This is good.
Can you hear me now?
Yeah, like an ice cream. Pretend it's right.
You don't want me to do that.
Okay, let me just introduce you to it. So this is Dr. Georgia Pavlopoulou. Great pleasure and honour to have her on our panel. She's an associate professor. She's deputy director of the CYP IAPT therapies at UCL, and also director of the National Autism Trainer Programme. And my question for you, Georgia, is how can we better integrate the perspectives of lived experience experts into efforts to improve mental health care for autistic people?
Thank you. Thank you for having me here. So we have heard so far from colleagues that something needs to change. There are things we need to do differently, and there's so many unanswered questions. So in order to do things differently, we need to involve autistic people. We need to hear from them in new ways that we haven't done before. So far, a traditional focus on within the person deficits, a focus on managing autistic people's behavior or managing autistic traits, often strips us as clinicians, as researchers, as professionals from our ability for our ability to understand autistic behavior, for our ability to care for people, particularly in times of crisis, when things get difficult, in times of mental health crisis. And we know that this goes wrong because we see so many people restrained, so many people over-medicated, and so on. We also hear and know from research and from autistic people themselves that autism is not a threat to well-being, but stigma is, blanket rules are, inaccessible services are, and the trap of adaptations as well. Very often people will say this is one or two ways of adapting our therapy room, but very often these are not thought well with autistic people. It is a win-win. It's not easy. It can be very complicated. It takes lots of time. It takes money. It takes lots of reflective practice and humility. But it is a win-win because research and practice can be better when we relate with people with lived experience, when we have member teams and we work across different neurotypes, and when these relationships represent true partnerships. And at National Autism Trainer Program, we have been thinking a lot about these things. We have been working a lot around partnerships. And true partnerships in research, in clinical practice, have an element of love, a kind of professional love, but love, the elements of active listening, of trust, of being honest, being transparent, being trauma-informed, and not deciding on your own, on bringing people after you have decided things. There's something about shared plans, shared decisions, and when we love people, we want them to be well in our presence. And I think this is the key thing we hear so much from autistic people, getting in touch with mental health services, or often getting in touch with us as researchers. Come and be well in my presence. It is an essential experience for autistic people. So the first key is to leverage their voices into true partnerships. The other key thing, I think, is we need to think of whose voices do we include or exclude. We need to leverage the voices of those that we don't hear often. People from Black, Asian communities, and even me saying Black and Asian communities is not potentially the right way to put it, because I put too many groups as one thing. Non-speaking people, people with learning disability, autistic people with addictions, autistic people with psychosis, and so on. Again, it is a win-win because autistic people bring in research richness, validity, epistemic justice. Sometimes they make very good friends as well. They have a sense of humor, they have attention to detail. And working across neurotypes this way is also a great way of developing empathy for the experience of each other and modeling that to the services. Recently, we have been working in a project led by Edmund Sonuka-Bark at King's with Anna Freud colleagues, UCL colleagues, and we have the joy of feeling the joys and the pressures of working across different neurotypes. And we have asked 20 young people to be co-researchers with us to help us to find ways to cut down risk for depression. And we're working with rather than on or for autistic and ADHD students. And it's really interesting, before even we go into a co-production mode around methodologies, the discussions that we have with the young people around how do we measure depression, what we call depression, does that resonate with their experience, the way we talk about emotion regulation, the way we talk about resilience. It is very obvious that many of the measures we're using are made by and for non-autistic people. Many of the concepts are not relevant. So again, we need to make sure we hear from autistic people. And then my next point is that...
Just say, we've got about 30 seconds.
That's okay. The last point is that we need to think about culture change in the services. Programs like the National Autism Trainer Program that is commissioned by NHS is not the full answer, but it's a good start to get people thinking about what neurodiversity-informed practice means, what an experience-sensitive approach to adaptations of mental health can look like, and programs that are co-produced and co-developed with autistic people can be part of the answer. Thank you.
Brilliant, thank you. Now I'm going to say, pass James the ice cream in the aim of unconsciously planting in your minds the need to keep it close to your mouth. So finally, to introduce you to Dr. James Cusack. So James is Chief Executive of Autistica, which is a UK sort of autism research, but I'd also say sort of policy and strategy organisation that many of you would have heard of, and is himself autistic. And my question for James is, at the level of policy and service development, in your view, what needs to change for autistic people to receive better mental health care?
Okay, so hopefully you can hear me. There's two barriers. The first one is whether or not I speak loudly enough. The second one is my accent. And everyone always tells me to elocute carefully. So the first thing that we need from a policy perspective is to understand that this is a priority. And I think everyone over the last 10 years has done a really amazing job of articulating that and making that point. And I think that's really, really important to actually ensure that people know that this is a real issue. And I was thinking about this on the train in, and I was sort of reflecting on a sort of an analogy to the point I'm going to make. And I guess the point, when I turned 39 on Saturday. I've got a 10-year-old and a 6-year-old daughter, and they're very generous. What they like to do is just let me know how the sort of emergence of my grey hair is developing. It's very, very kind. But the thing about that, and the thing that I was telling them, is that it's predictable. So we know that that's going to happen. And when we know that something is going to happen, or it's likely to happen, not everyone gets grey hair, we can do something about it. And if it has an adverse effect, the grey hair is fine, it's not a problem for me. But if it has an adverse effect on somebody's life, we tend to do something about it. In fact, in the health system, that is what the health system does. If we know that someone has condition X and it will lead to condition Y, we try to stop condition Y from happening. But for some reason, if you're autistic and we find out that somebody's autistic, we haven't really developed a culture and a way of doing that yet. So we kind of wait to see if they develop anxiety or depression or some sort of mental health problem. So one of the first things that I would like us to do differently from a policy and a service development perspective is how can we stop this from happening before it happens? So how can we help support autistic people's mental health, create the right environment, really prioritize that in a way that's really beneficial? Because if we can, that's a win-win situation for everyone else. I think the area which we focused a lot on, and where there's been a lot of focus in terms of the discussion, is on development of interventions and rolling those out. I think that's absolutely fantastic. I think we need to sort of understand more about those individual differences and also the stories that people have on the road to sort of getting into sometimes quite acute crisis situations as well. So I think if we can do that, and we can think about the system and what we need to policy change we need to achieve, I think there's a real opportunity here and a real opportunity to make this point to politicians, which is, first of all, politicians get scared when they think something is too difficult and it can't be solved. But this is actually a scalable set of issues where we have solutions in mind. We know that we need to get better at assessing and supporting autistic people. There are 185,000 autistic people waiting for a diagnosis right now. We need to innovate and find ways to change that. We know that autistic people are likely to experience mental health problems. We need to support practice to find ways to change that. We are beginning to understand what doesn't work, and we know what we need to do to understand more about that, which is more randomized controlled trials. And we can understand why people access acute mental health services as well. So for me, it's about being able to tell that story, being able to show to key decision makers and people involved with service development that there is a better way of doing this, a more effective way of doing this that will benefit autistic people and society and lead to better mental health. And so from my perspective, I think we have an opportunity to tell that story. And I think that's what we really need to focus on. And that through the general election will be something that actually we'll be talking about quite a lot.
Thank you very much, James. And thank you to all our panel who've now answered their question and been introduced. And so now is our chance to throw the floor open to you all to ask questions. And I've seen a hand shoot up already at the back. So yeah, lady in the black top at the back there.
Hello, my name is Jan, and actually I am on the steering recently taken the National Autistic Trainer by Trainer course. It's a 4-week course in medical settings. So I will be out there, explaining what I myself am autistic people. And what I'd like to say is that the National Autistic Trainer for Trainer program in medical settings, there are also other, settings like in colleges as well as adult mental health. So I would, go to the Enterprise Center to look at the details of that. And also, what I'm going to say will address some of what each one of you has said. Because autism, I'm actually American, but I was diagnosed here both autism and ADHD with a monster late life diagnosis 2019 to 2021, before actually one of them during the pandemic. So what I don't hear is that women actually have been sort of like shafted. Essentially, we are trying to understand what autism is all about, largely because women have been left out, and that's a big, huge part, which women present autism quite differently. There are some commonalities, but the way it's presented, it's quite different. And because women have masked all our lives, part of that is hidden away. So lots of women don't even understand that what they've been masking is actually autism. That so many women have been misdiagnosed, given antipsychotic treatments which are not meant for them, and also shut up in institutions, and basically, they have suffered, young girls actually. So my goal actually, I'm also an autism advocate, is to, not only raise awareness but acceptance of what autism is all about. In particular, how it presents in women and what should be done. Also, autism comes, kind of correlated to a lot of physical disabilities too as well. For instance, I have lots of hypermobility, the joint problems, as well as, like EDS, which is Ehlers-Danlos, and also, recent research in the US have proven that, fibromyalgia and other autoimmune, physical problems like MS, multiple sclerosis, actually it's also can be correlated to autism as well. So, and in what I've done is actually I've used the diagnosis to ask for reasonable adjustments when I get treatment from King's College, because I have lots of sensory processing issues, so you can use that as a reasonable adjustment.
Yeah. Thank you.
So
thank you.
It's important to do that.
Yes.
So consider the women's part of it as well.
Thank you so much for that comment. And I'm just going to very briefly summarize it because otherwise the people on the website on the web can't hear it. There was a really important point there about how autism presentation could be influenced by a person's sex/gender, and that's been a big part in people not being recognized. Also, I think about misdiagnosis and the overlooking of physical health challenges that many autistic people experience. So thank you for that. So I'm going to go with with Kate in the check top there, please.
Can I just add though?
Oh yeah, sorry. Sorry. My apologies. Yeah.
Yeah, I just wanted to reaffirm on the basis of our systematic reviews, most autistic participants in the studies were white and male. So major research and evidence is missing that will be more diverse and include, at the moment, underrepresented groups. So, yeah.
Yeah.
Just wanted to say.
Thanks for that, Tamara. Yeah.
In thinking about the need for more research, I can hear that there is something about we need more RCTs, but I'm wondering if anyone can speak to it feels conflicting, or the paradox, or the friction between how controlled an RCT needs to be versus how individualised we know treatment for autistic people needs to be, and how do we balance that?
Yeah, thanks for that question. So that's a really interesting question about, if you like, a sort of tension that exists between, on the one hand, the need to do carefully controlled trials in which there's a sort of standardized measurement versus the great value of kind of lived experience research, if I've understood correctly. Who would like to engage with that? Yeah, Eloise.
Brilliant point, and I was thinking the same. And it's such a balance, isn't it? Because, yes, we need the RCTs to convince the people in policy and to get money, and that's really important, and bring on the election, because hopefully we'll get more of that money into where it needs to be. But also, we need good CBT. Isn't really CBT for anxiety or CBT for depression. It's CBT for the individual that you're doing CBT with. And that might not just be CBT. It might be some CBT, but some other bits that are really meaningful for them. It might be some CFT. It might be, I don't know, thinking about their identity. It might be thinking about systemic work. And I think single case experimental designs as research, where you're actually thinking about an individual variables that matter to them. It might not be, has your anxiety got better? It might be, have you got to go to the poetry slam that you're really passionate about that's been really scary? So I think that's a really good point, because we need to talk to the nuance as well of a huge group of people who are really brilliantly, wonderfully complex. And RCTs can't do that alone, but they're really important as well. So I think we need parallel kind of research endeavours. But lovely point.
Thank you. And Dheeraj, would you like to add something on that?
Thank you. Yeah, that's a really important point that's raised, and the discussion following. I just wanted to add a very quick point that these are not a sort of one thing or the other. You can actually design interventions which are individualized approaches and still do RCTs of those individualized approaches. I mean, the idea behind the RCT is that it's the least biased design. So randomization helps prevent or reduce the possibility of bias. And you can still do that with individualized interventions. Maybe we should think about more of these.
Yeah. Yes, go on.
I think in terms of participation, if we think about it, it's also about when do we invite autistic people to be part of the conversation. So I'm very much fan of the concept of co-intentionality. It can be, very often in qualitative research, people think it's much easier, co-production, but it shouldn't depend on methodology. Co-intentionality can happen on the hard science, on RCT, but it depends on how early on we allow really autistic people to take key decisions about what the RCT is going to be about, how it's going to look like, and if they're going to report, because from many of the reviews we have heard, very often is the clinician reporting how successful or not it was, whatever we have tried.
Thank you. Right, I'm going to take, I will come back to you, but I'm going to take a question from the Mentimeter, just because, and if that's, okay, quickly, and we've got a lot of questions, but if you'd like to just say something, go for it. No, go on. I'm curious now.
I was just going to say that maybe not all adaptations need an RCT. So what we identified from the adaptations when we pulled together all the studies is that some were just simple, reasonable adjustments, not necessarily really requiring an RCT. So.
Yeah, thank you. That's a really helpful point. Okay, so this one here, one speaker mentioned masking, and that's already come up again in our questions here, both conscious and unconscious. I wonder what the panel suggests as possible ways clinicians can use to be aware and reduce these behaviours where appropriate. I wonder, Amanda, would you feel say something from, sounds like someone who's been on one side of that interaction with clinicians. Do you have any thoughts on that?
Yes, I do. I'm first going to try and see if I've got like one I've planned, just to save me.
Would it be helpful if someone else spoke a bit and then we came back to you on that one?
Yes.
Yeah, brilliant. Has anyone else got any thoughts on masking, camouflaging, and how to sort of work with that in a clinical context? Brilliant. Eloise?
So yeah, as someone who is a clinician but has also been on the other side and has had therapy, I think you've got to feel relationally safe, and that's not a given. And to feel safe, you've typically been misunderstood a lot of your life as an autistic person, and have understood is probably the least of the problems, stigmatised, etc. And actually having someone who's making those adjustments, making the adaptations, is going to understand you from the bottom up without those assumptions of, oh, you need this, before you've really got to know them. Or like, how do you stop masking when you're kind of not sure if someone's going to see the real you and go, oh no, I don't know what to do with this. You know, it's really complex, and it's got to be. That's why, as I think we talked about, the sort of 6-session models. Does that work when you may have had experiences of feeling relationally unsafe? Probably not. So I think, yeah, it's complex, and it's got to be from the bottom up to help. And also, no one has to do that. That's a choice, and that's a power in having that resistance to put that mask up and not be vulnerable. And that's a really important thing to not have to take away from someone unless they choose to.
Thank you. Amanda.
Yes, hello again. Yeah, I'll start with kind of what I've noted down as potential solutions, and then I might kind of dip into a bit more lived experience. So similar to one of the first points I raised, there needs to be more flexibility in terms of contact methods, not just for the referrals, but the therapy itself. So in my experience, I mask far less if I'm able to build like a face-to-face rapport with the person I'm working with. So that can include video calls as well, rather than like I've had a past experience of phone therapy, and it was very unclear how effective that was because I was kind of masking, which can include also masking how well the intervention is actually supporting me. So also being mindful of how the autistic person is responded to when they highlight issues that for them seem to be key to the problem they're seeking help for. So it actually may be helpful for the clinician to ask more questions and explore that issue further, even if it kind of moves outside of the structure of CBT. An autistic person may not come across as distressed, as they could be masking over it in that moment. So I know for me, sometimes it's after a call, a video call or a phone call has ended, that then all the kind of emotions hit afterwards, because I drop the mask because I'm not using it to communicate anymore. And then even physical health symptoms can also get masked over as well. So I can actually, it's almost like they get shelved for a while, so I'm masking so intensively, and then once the mask kind of drops, which isn't like necessarily a conscious act, then I'll also be like, oh, actually, I need to actually be looking after my physical health as well, because things have cropped up even because of the anxiety generated through trying to navigate that like social interaction. So yeah, there generally seems to be a need for more time to develop the relationship between the clinician and the autistic person. As from what I've experienced, as I relax into that professional relationship, then the anxiety lessens, and the clinician and both myself realize that masking itself starts the lesson. So we actually get to, really kind of get into like the meaty part of what the support is that I would need, because I'm actually able to more freely talk about where the issues are. So yeah, oftentimes just as we're starting to work better together and there's less masking, if it's like a prescribed course of CBT, then it could come to an end just as we're starting to kind of make progress. And I'll just, if there's time, touch on. Yeah, so just this one point. The most problematic response I've had for masking is where a clinician kind of has this acknowledgement, oh, well, everyone masks, or, everyone has like a social persona that they switch around depending on who they're talking to. And while this is true, the differences in degree to which an autistic person masks and what's actually going on there, and the impact of masking on their well-being in and of itself are also valid and need to be considered, rather than feeling like it's dismissed when seeking support, and it's almost like part of the communication problem. So if it's part of the problem, it needs to be addressed. Otherwise, what's being focused on, how is the help being delivered?
Brilliant, thank you. Now, unless anyone in the panel has a burning desire to talk on that one, I think we could move on, just because I think there's lots of great questions out there. Woman in the blue shirt.
Hi, Sarah. I don't know you will. My question is a bit of a making mine, and I think it's based on a lot of the reflections that have come up so far of there being a lot of small changes that can really kind of happen to improve care immediately and drastically, and for the panel, what kind of like, I guess, culture change can take a bit of a long time, what that like smallest step that can happen
Who would like? So I think Georgia and then Tamara. Yeah, great.
Yeah. It's something we discuss a lot again at the National Autism Trainer Program, and for that reason we often talk about ripples of change. And finding the goodness that we all have as clinicians, we care, that's why we are in that job. But very so often, our heuristic biases, the way we make everything so automatic and so manualized, can come in the way. And it's really, really heartwarming to hear from people the little things. It's really the little things that often don't cost money as well. It's some kind of reflective attitude. It's little things in the environment that can make massive difference for people. With colleagues at the National Autism Trainer Program, autistic colleagues, we co-authored a paper called An Experience-Sensitive Approach in Clinical Care. It's not rocket science, it's nothing really new, but it's about recognizing the uniqueness and not putting all people under one umbrella and understanding what is their social comfort, their sensory comfort, very simple things. In a very fast-paced environment where clinicians are also burnt out with so many challenges currently, I think it is the little relational things that can make the difference, and being very honest with people. Maybe there are things that we cannot change in this room for autistic people, but can we let them know in advance? Can we prepare them? Can we be accountable? I'll stop here.
Thank you. Would you like, Tamara?
Yeah, I completely agree with everything you said. I would highlight, I think it's extremely important for clinicians to stay curious and ask about their needs. What are the needs and what are the preferences? Often it's the need for that kind of space so that the autistic individual receiving care can then say what is it that they need that at the moment perhaps sometimes it's not the case, and some kind of simple adaptations largely can be in terms of communication, so being very clear, simple in using sort of preferred language is something that can be taken up, I think, sort of perhaps easily, and then adjustments to the physical environment as well, I think could do as well.
Brilliant, thank you. James?
Yeah, so I guess it follows on really logically from Tamara's point. The first thing is all of our mental health is improved when we understand ourselves. So, the first step to improving autistic people's mental health in many ways comes with having a process of assessment that's useful in terms of helping people to understand themselves and who they are and how they relate to other people, and helping other people to around them to understand what that means and how they can help as well. And I think we can get a lot better at delivering that information a lot more quickly, in my opinion. So I think that is one area where we can make real improvements. I think the second way in which we could really just deliver a change is to actually just make a genuine commitment to prioritising autistic people's mental health and well-being from the moment, like I said earlier, they get a diagnosis. So actually being proactive about planning that, realising that that's a huge enabler of everything that autistic people do, so we can make proper adjustments, properly prioritise the things that autistic people value in their lives and make them feel like it's being valued as well. So I'd love to see that, and I'd love to see that happening in kids where they have a positive sense of themselves and a positive sense of an understanding themselves and the people around them of what it is that helps them boost their mental health. And as has been said, you don't need an RCT for that. That's just about developing sensible approaches based on listening to people and their stories. And I think we can learn a lot more about how we can do that effectively.
Great, thank you. Right, I'm going to go for Rachel. So I'm now self-conscious about commenting on people's clothes. The woman in the wonderful wavy fabric dress. There we go.
Thank you. My question risks getting bigger the more I hear because there's so much I want to ask. So my question is about training mental health practitioners who are autistic. And so I would love to hear a perspective from clinical trials and from lived experience of people who are training. So my context of training is the 6-session CBT. So any advice that you have for me as a trainer in supporting trainees with autism working with brief CBT interventions would be great.
Okay, well, I think Georgia, great, and Eloise, you may well be an obvious candidate to also talk about this.
So yeah, great question. And I think there's loads of us in healthcare already, and that's brilliant. But there's loads of people who don't feel able to say that they're autistic or neurodivergent in healthcare, and that's not brilliant. But it's important to note that because it's not safe always to be open about it. And I think the first thing is actually feeling safe to say I have neurodivergence. Also, diagnoses, you might want a diagnosis, but 4 years later you're still on the waiting list. So how do you support people who are thinking about it but don't have that rubber stamp? Should we have a rubber stamp for an identity? I don't know. But yeah, I think we need a culture in healthcare where it's not them and us. It's not, we're treating these autistic people or these neurodivergent people and we're separate from that. Our own identities to neurodivergence are complex, and they might be personal, it might be family, friends, and it's a culture change. And that's a bit of a woolly answer, isn't it? Because what we want tangibles, but
We talk about encouraging people to disclose. So for me, and more trainees are disclosing neurodivergence, more ADHD, but more autistic. And as a trainer, particularly training people who may be masking, who may be, wishing, particular ways of sessions, any advice that you have that I can hold in mind in supporting people with autism, who are training to deliver low-intensity CBT interventions?
Unfortunately, it's not always safe to say to people to disclose. People will not feel safe. It's the same with dropping the mask. Very often we talk about that, but it might, for many people it is not safe. So there's something about safety and creating the circumstances, and people know that they're not safe. Again, it's something we get a lot when we have neurodivergent people in the training who are clinicians, and they talk about the daily hurts and stripes in the system. By the way, they hear other people talking about autism spectrum disorder. By the way, they read reports about others. The ableism, if you like it, that exists consciously and unconsciously. And that makes it very unsafe for them very often. So I think there's something about safety, there's something about the language. Even the language one has on their website about how they talk about autism. When they talk in their clinical teams, when they hear the colleagues talking about autism and ADHD from a very old school, if you like, a deficit perspective, it can be a very hurtful experience for many of them.
Sure. So we've just reviewed the applications, we've had 1,300 applications, and more people are writing on their personal statement their reason for coming into mental health and disclosing on a form. So then more people are. So just anything more you can say about those people who do make it onto our course about how we best support them.
I think Georgia's point about as a clinician, you're hearing microaggressions, about ableist microaggressions daily, constantly, and that's really tough to then be like, my identity is also the same thing that you're talking about, and it takes thickened skin, and it takes having a bit of power in the system yourself to be able to weather that and say, actually, I don't think that's appropriate, or to sit back and let it happen and know that someone else needs to do that and that's not your fault. So I think we're not there yet where people are going to be able to disclose, and lots of people who are disclosing is brilliant, and it's great that you're wanting to support them, but there's lots of people who aren't able to disclose yet, and we need to support them to feel safe too. Sorry.
I was really interested in your question. So one of the things that people quite often ask me is because we have quite a high proportion of autistic people in our team, and they go, how come you got so many autistic people working with you? Well, beyond the obvious question that we're an autism charity, the response we're an autism charity, so people are naturally very interested in it. I do think there are things that we've unintentionally done effectively. So I did a bit of after the pandemic, I sort of had coffee with everyone in my team. And one of the things that really came, like on a one-to-one basis, everyone in my team was just that actually we kind of had a culture of just asking everyone what sort of adjustments and support they needed and how we could effectively support everyone. So actually, it's really less of an autism question and more of how you set a culture, which basically says, how how can we support you? How can we adjust what we do to make sure that you get the most out of this situation? And I didn't really know that we did it, if I'm honest with you, until some of the people who weren't autistic in the team went, actually, the fact that you asked that and asked how can you do it, and you didn't make me pretend that I was amazing at everything, was kind of helpful. I think that we've got better at that over time. We're still not a perfect employer by any means, but I think that really helps. And so I think it's less of an autism question and more of a neurodiversity question, which is like, actually, how do you construct a process which is as inclusive as possible for everyone, and means that you can adapt what you do to ensure that everyone can thrive and be as successful as they can within the context of the programme.
Brilliant. Thank you. Right, I'm going to go for one more question off Mentimeter, and then we'll take questions from the floor. And I'm going to, if that's all right, direct this one towards Dheeraj, if you don't mind. So there's been a lot of talk about CBT and DBT, but aren't these short-term interventions? What about interventions for late diagnosed adults with long-term mental health problems? I just wonder if you had any thoughts on that.
That's a good point. Long-term mental health problems, I presume people are talking about chronic depression or psychosis. So,
yeah, and just maybe just prolonged high levels of distress. Yeah.
Bipolar.
Mm.
Yeah.
Anxiety, extreme anxiety.
So the anxiety treatments, I was saying these for the common mental health issues like depression and anxiety, there are trials that are happening at the moment. I guess when I was describing the sort of trials landscape at the moment, we made a start, and there are many, many different interventions that await to be looked at. I just hope that we will and the funders will continue to support this. Autistic people will continue to wanting to take part in these studies, etc. Should also say, which I should have pointed out earlier, is that there's one question often asked about whether we can just use the evidence from what we know from trials generally in mental health, which we do already. Having said that, a lot of autistic people report back saying, for CBT, for instance, it's not accessible to me, or it's just not the right structured in the right way for me. So adaptations are required. For mental health medications, psychotropic medications, very commonly prescribed. Very many people will say, I've got these adverse effects which, were not listed on this, on the information sheets, etc. So we do need, we do just need to do more research in these areas.
Yeah. Great, thank you. Right. Woman at the front. Yes, thank you.
Just following to the point, when autism getting the category of mental health, the first point is to give to the person medications, how it control the medication, because continue, and the person gets worse instead of getting better. And in case then we can talk about what about social prescribing? Is there any opinion?
Yeah, that's a really interesting question. Funny enough, that had popped into my mind just in relation to the last question. The question is fundamentally, what about social prescribing and other of these more kind of system-based, non-drug-related interventions?
I can just begin by that, saying, in our service in Bristol, we have a very active and quite a large social prescribing service as a post-diagnostic support in Bristol. So we have between 3 to 4 social prescribers. And so that is one intervention we're actually testing out in a small-scale local effort for now. But if it works, early signs of sort of success, then we'll work on delivering, maybe designing larger studies on that, systematically understanding that.
I just want to say very quickly on the social prescribing point. I spoke with someone from the NIHR about this and about whether or not this is the sort of thing they'd be interested in supporting. And interestingly, they're discontinuing their trials in social prescribing, I understand at the moment. And it's a design issue in terms of getting a signal, so being able to demonstrate its effectiveness. So basically, they think that clinical trials aren't the most effective way to demonstrate the effectiveness of social prescribing or where it is effective. So it's a really interesting point. It sort of speaks to some of the earlier points and questions around whether or not RCTs are always the right things. For different sort of methods and approaches, you might need different research designs to demonstrate efficacy, because for some reason social prescribing doesn't respond well to RCTs, although I think there's good sort of face validity to it. Anyway, so yeah.
Thanks, very interesting. Right, we are at the point of our final question, and I'm going to, I'm in a dilemma here. I'm going to go for the person in the middle, typical clinical psychologist. I'm going for attempting a compromise here. So, gentleman in the white shirt, please.
I'm interested to hear from the panel what your views are on what should be, at a service level, what should be the mental health support for autistic people who doesn't have that severe mental illness, i.e. schizophrenia or bipolar, but many other mental health disabilities.
So this is a question about what services should be provided for autistic people who aren't necessarily experiencing things like psychosis or bipolar, but were you thinking people who nevertheless are experiencing mental health challenges like anxiety, depression, and so on? Yeah, would anybody like to jump in on that one?
Yeah, really good point. And I think, I don't know, and the commissioning gods need to do some recommissioning maybe, but I think we need to do post-diagnostic support. Well, we need to sort out the diagnostic system because there's 185,000 people waiting. They might be waiting for years. That's increasing all the time. We need to sort that out. And then we need to offer post-diagnostic support because people are getting this, yep, yes, this is a thing for you. And then they're being left back to go back into the world without, oh, okay, I've got loads of questions that are coming gradually, or I'm developing my identity and I don't have anyone to talk to. And actually there's a lot of social disadvantage in who gets support and who doesn't based on cultural capital. If you're non-verbal, how do you get that support? How do you get a community that helps you understand yourself? So I think that's got to be something we consider. But yeah, I don't know. There's lots and lots to think about.
I think we need to go away from the misconception that we need neurodevelopmental pathways. Everything needs to be very specialized. For one, it seems like it's not funded anymore. And for two, most people will work with diagnosed and undiagnosed autistic people. It's 1 in 36 people now, I think, the ratio. So, you know, very often I hear from CBT practitioners or other practitioners, but we don't work with autistic people. You think so? Probably you have done already. So there's something about that, making autism education, autism training a mainstream thing, or making services neurodiversity informed more broadly.
So, you know, I think where we are, there are several ways of characterising where we are right now. And one way of characterising where we are is in some ways the price of success. So, you know, actually, when you look at where, I was in Washington, you look at where different countries are, one really positive thing that we've done is we've really helped to change attitudes towards autism and sensitivity to neurodevelopmental differences, which is a really positive thing. So there's a recognition of the need, but we haven't developed strategies yet. I think, as I said before, and I'll keep saying this, is that the moment we identify any form of neurodevelopmental differences, we need to be thinking in the context of that person's mental health and recognising the increased likelihood of mental health issues. Because if you're diverging from the norm, then how the society is set up is probably not going to be optimised towards you. It's going to be optimised towards the person in the centre of the bell curve. And so for me, support needs to start from that point. What I can tell you, and what we regularly hear, and I've just spoken to somebody on Sky News today, is what parents and autistic people are experiencing is actually trying to explain that they have mental health issues, and quite often been kind of gaslighted, been kind of told that it's actually just part of being autistic, having anxiety, and there's nothing we can do for you at the moment, or sorry, you know, the things that we have won't work for you, you know, kind of that's why we don't deal with autistic people, and that's really worrying. And so instead of taking an approach around prevention and being really proactive about this, actually we're doing nothing, kicking the can down the road, and then that's leading to some pretty tragic and unfortunate outcomes. And so we really need to see significant system change to really address these issues, in my opinion.
Are you going to say what the
Thank you.
figures are for suicides for adults, autistic adults? They're quite crucial, and I don't think anybody mentions it.
Yeah, well, yeah, it's just to say that, you know, we know from data, in particular from Sweden, that there's an increased likelihood of suicide in autism, and that, in particularly if you're autistic and you don't have a learning disability. But and there's all sorts of evidence that sort of supports that, and there's also all sorts of evidence around suicide and suicidality. We do know that autism has been prioritised within the suicide prevention strategy, which is good and something that we've worked on. That is part of the solution, in my opinion, but the solution starts with stopping that journey towards feeling that way as well. And I think we need to invest a significant amount of resource in that as well.
Thank you. And we're going to just finish, that's okay. I think, Amanda, you had something you were going to add to that. And then, Eloise, did you also have something?
Oh, no.
Okay, so Amanda, brilliant. Thank you.
Yes, hello again. This was primarily in response to the initial query, which was about autistic people seeking the kind of like the non-severe support for mental health. And just in terms of my experience and all the autistic people I'm aware of, the referral pathway is basically the same. So that might mean going to your GP first, or you might kind of self-refer via the NHS's online talking therapy service, which used to be called IAPT. And what tends to happen then is you might get prescribed like a low-intensity course of CBT. And what I would say in response to like how could that potentially be made more effective for autistic people is potentially offering autistic people more sessions than is typical. So if, say, for example, a typical course of CBT is 6 sessions, it might be helpful to have like 2 or 3 additional sessions because of that whole sense of needing to kind of work on lessening the masking in the therapeutic process, so there can be more genuine progress being made, not progress kind of based off of the kind of social communication difficulties that present in that first meeting of a new person. Also, more signposting to services which do have the flexibility of more long-term support. So I had the most substantial progress with my well-being after following a traumatic bereavement when I was referred. So I didn't know this service existed, but I was referred, thank you to UCL, Student Support and Wellbeing, to a charity which focused on people with disabilities and health conditions. And that kind of long-term support was key and instrumental, but I wouldn't have known that even existed if I wasn't signposted that through my university, and not all autistic people have that opportunity to be signposted in that way. And then lastly, ensuring that client-led or client-centered sessions really are. And this may mean letting an autistic person prepare what they'd like to bring to therapy in advance, or even email content ahead of a session to facilitate working around those social communication issues. And this may be in addition to the homework tasks that CBT sets, just having a sense of openly saying, oh, you can message ahead if there is something an issue that's come up outside of the CBT task that's been set.
Brilliant. Thank you very much. So we are out of time, and I'm really sorry if you've posted a question on Mentivita or via other of our multiple channels, or I didn't get a chance to ask a question in the room. What I would say is that we now have drinks available. So if you've still got an unanswered question, please do come along to that. I'm hoping that many of the panelists might stick around for a bit, and you can ask those questions then, and hopefully we can continue our conversation. So thanks so much for coming, and thank you to our wonderful panel.